Well, Depart- welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I have some logistics to go through. This CME activity is jointly provided by the Queen's Medical Center and the University of Hawaii Jabson Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You will be able to find the evaluation by following the link in the chat at the end of this presentation or on our advertisement or on our website. Our sponsor sends out CMEs in mid-January every year. Your comments are very important to the planning committee and will be used to plan future programs. Before we proceed, I'd like to share the following financial relationship disclosures. Dr. Dietrich, today's speaker, is the current Associate Chief of Staff for Geriatrics and Extended Care at the VA Pacific Islands Healthcare System and the owner and manager of Heart Hospice LLC. She has previously served as the Medical Director for Palliative Care Services at St. Vincent Healthcare, the Regional Medical Director for Hospice Compassus, and was the former owner of Discrete Reductions LLC. I am so pleased to welcome Dr. Katherine Dietrich. She worked at hospice and palliative care for almost 15 years. Most recently, she was medical director for palliative care services at St. Vincent Hospital in Billing, Montana, which was home to the largest palliative care program in the state. She was also the lead regional medical.
Hi, Dr. Masaki. You're frozen.
Beaches. Welcome again.
Okay. Can everyone hear me okay? Can somebody give me a thumbs up to know that my audio is functioning?
Yes, your audio's functioning.
Okay, wonderful. Just didn't know with Dr. Masaki being out if that also impacted me as well. So, well, thank you guys for having me here. And it's been a wonderful experience the last 5 months getting to know Hawaii and the VA. And so I won't go through all of my disclosures again as Dr. Masaki covered them, but I'm here to talk today about pain and symptom crisis management. Usually this is directed to more of an inpatient setting, something like a hospital where we can do drips, PCAs, things like that. But a lot of the outpatient world is now getting them. And so like CLCs or nursing homes, sometimes hospice houses, things like that. So it's becoming more and more relevant as our patients are getting sicker and having more acute. So as I go through, feel free to raise a hand or to put things in the comments. And if someone could alert me if there is something in a comment and I'm not seeing it, then I would appreciate it. So, and then there should be time for questions at the end. So again, I won't go through all my disclosures. Dr. Masaki kindly did that for me. So my goals today for everyone are to be able to identify a symptom crisis. And that sounds really easy, but sometimes we miss things, and especially in our geriatric population, to improve management of acute pain in an inpatient setting, to appropriately manage the titration of drips and PCA during crises, to expand our clinical knowledge about medication options for nausea and vomiting, to increase medical knowledge of treatment options for shortness of breath, the end of life, and then to improve understanding of palliative sedation and when it might be appropriate. So I always like to start with like a little like historical fun fact information. And especially where pain is concerned, I think we've come a long way. We really have. Sometimes it doesn't seem like it, but when we look back, things like some common causes of death or pain crises in medieval times were things like plague, childbirth, violence. You could die by heresy. a lot of people were injured in things like hunting accidents, read stuff like being mauled by a bear, gored by an animal horn, shot with arrows or other things. And then, of course, we had things like early or sudden death, probably early MIs. But there were a lot of ways that people died that were very, very different back in the medieval times than from what they are now. And if you can imagine, they didn't have things like morphine. They didn't have Dilaudid or fentanyl or any of the things that we use, or even the non-pharmacologic modalities that we have today. A lot of them they didn't have. So, and I just gave some like famous examples of things. I learned that you did not want to be a wife of King Henry VIII because a lot of them died, not always by natural causes. So, but just some fun facts for people to look through. So I always think like we can do better. We can always do better, but we have come a long way. And so as we go forward, we're going to kind of look at pain. Primarily, this lecture is on pain and symptom management. So we're going to look at pain specifically, and then shortness of breath and nausea. So this was a really interesting study that how we judge pain, how we consider pain in our different populations. There was a study in Lebanon that looked at women in labor and delivery and patients in orthopedics. And both patients and doctors were surveyed about the patient's pain. And it was very interesting because 50% of the OB patients and 37% of the ortho patients reported severe undertreated pain. Excuse me. And if you think about that, these are both locations or situations where we really should expect pain. Like this is not an unusual, like unseen symptom or event. I mean, if someone's going in for a new joint, if someone just had a baby, it would seem obvious where their pain would come from and that they might have pain. And yet we did a really, really bad job of estimating patients' pain or considering patients' pain. And some of the unfavorable practices that they found that when they compared when the patients expressed pain and when the doctors thought they had pain were that the pain was not being assessed prior to medication administration, which is really scary if we think about it, because how do you know what to give if you're not going to ask how bad their pain is? And then also having to wait over 30 minutes before getting pain medication. And if you think about, again, if you're having severe pain, 7 or 8 out of 10, 9 out of 10 pain, do you want to wait for over 30 minutes for that pain medication? Probably not. So it was a really good study looking at the incongruencies between what physicians or providers expect versus what patients are experiencing. And so what we noted from that was that the provider's satisfaction with the pain control was independent of the patient's satisfaction with the pain control, which seems just crazy and ridiculous, but it was true. And how often do we see that? I would say probably pretty frequently, actually. And then there was a disagreement in the satisfaction with the pain management, and that was attributed to the subjectivity of the pain experience. Maybe people feeling like it shouldn't have been as bad as the patient reported it to be. Difficulty in accurately quantifying the pain, and then different interpretations of the intensity and the treatment response. So maybe the physician gives a dose of morphine and expects the pain to get a little better, but the physician expects it to get a little better, but the patient expects it to get a lot better. So there's differences in what the expectation might be. And also there's unfortunately this belief that or perception that patients will exaggerate their pain, which is not always true. So we have to be very, very cognizant of. And so the highest levels of dissatisfaction were patients that were not asked about their previously used pain medication. So their feelings or perceptions of how previous medications have gone was not taken into account. They were not questioned about the pain severity prior to being given the medicine, which again seems hard to believe. And then the timeliness of the medication administration, which seems pretty obvious. And so the takeaway is really engaging patients in their pain management improves outcomes. The more that they feel that they've given necessary information, that they've been adequately assessed, and that they receive the medication in a timely manner will really help with your outcomes. So I like to ask this question of people, and it's so interesting always the answers. So which patient demographic has been shown to receive less pain medication? And I don't know if we can put in the chat, or if there's some answers that people want to throw out. Does anybody have any guesses? Okay, I don't see a chat, so I'm going to say that nobody put in an answer.
I think
The
most people
answers-
are saying C. Most people are saying C.
C. Okay. Yeah, I'm sorry, I can't see the chat. So going back, so patients with developmental delay, correct. And we know that when we look at patient demographics, the people that are least likely to get pain medicine or get less pain medication are pediatrics, minorities, elderly greater than 75, which comes in for a lot of reasons, a lot of different reasons. Interestingly, the answer used to be males, and now there's more research coming out that females actually receive less pain medication. And that they're over-reporting their symptoms. Patients with dementia, mentally handicapped patients, and then chronic opioid users because there are stigmas associated. So I want to go into a bit about what a pain crisis looks like, because again, this should seem obvious. Most people think that they know, but then I'm going to present a case where it might be apparent that it was less obvious. So normally when we think of a pain crisis, we think of someone that's writhing in bed, retching, or having dry heaves, vomiting, moaning, crying, screaming, or just unable to speak, grimacing in the fetal position. And then I put this picture of a sloth next to it. And the reason is that in the geriatric population, I really encourage, I taught medical students and residents for the last, oh, Dr. Misaki, you've got an open mic. And so primarily I taught in a hospital, and most of the patient population that I saw was geriatric. And a geriatric pain crisis can look significantly different than a pain crisis in a younger patient population. And so if you get an 80, 90, or 100 plus year old, instead of seeing someone who's writhing around the bed, who's retching and has dry heaves, or who's actively vomiting, they may not have the physical capacity to actually do that, to be that physically active. And so sometimes what you see looks a lot slower, and it looks a lot calmer. And so people take that as there's less pain, and that's not necessarily true. And we'll get to a case a little bit later on where we kind of talk about that some more. And again, if there's any questions, if anyone can alert me, just speak up to what's in the chat. So this case presentation, all of these case presentations are patients that I actually saw in the hospital. They're real people. So this patient was a 92-year-old female who had severe peripheral artery disease and a left lower extremity that with a new onset cold pulseless foot. She was diagnosed with an acute arterial occlusion. Like, the goal here is not to confuse you on what the diagnosis might be. It was very obvious, an acute arterial occlusion. The patient and her family was wonderful. They were just the nicest people. She's 92. She'd been living in a home. Her quality of life had declined significantly in the last few years. They did not want any surgery. They didn't want her to lose her foot, to be amputated. They just wanted her out of pain and comfortable. Her pain had been getting worse since admission, but it was bad on admission, and she had been unable to quantify it. She had actually been pretty close to writhing, But when I saw her, essentially it was hours later, many hours later, and she was kind of barely moving in the bed, kind of moaning occasionally, not awake, confused and verbalizing things, but wasn't making any sense. And the family had stated that when she'd come in, she had vomited a few times, but it had stopped. And so just contrast this with someone who's let's maybe say like much younger, who's 40 or 50, who has an acute arterial occlusion, who would probably be, ripping things like ripping sheets off the bed and rolling around and very, very verbal, would probably be vomiting and vomiting and vomiting. But at 92, they just don't have the physical capacity. So really consider that when you're evaluating someone, like take their age or their status into account, their functional status. So she was in a severe pain crisis. What I try and teach all of my medical students and residents to do is the 4-step process when they're looking at a pain crisis. To first do a situational assessment, then do a medication assessment, to implement immediate and delayed interventions. And the delayed part is crucial. And then to reassess frequently and maintain pain control. So we'll go into that with her. The situational assessment is really looking at the type of pain the patient's having so that we can best treat it. Is it acute versus chronic? And then are there any other complicating factors, things like renal failure, medication intolerances, something else that we need to consider when we're looking at maybe what pain medicine we're going to choose? So in this case, pain was vascular/neuropathic. It was definitely acute. And then the complicating factors that she had were acute renal failure and that she was intolerant of Dilaudid. So all of those things kind of go in as we're thinking about what medication we want to give. So from the perspective of what medication should we use, well, we want to know what's been tried, what worked, what didn't. That's really important. And then how much, what dose was given. Sometimes we see, like, if you imagine that you have a headache and someone were to give you 1/8 of an aspirin, of an 81 milligram aspirin, would that do anything for your headache? Probably not. So sometimes we will see that too, where people are like, oh, I've tried fentanyl, I've tried Dilaudid, I've tried this, I've tried that. But did you give enough for it to work? Like, did you give enough of a dose for it to be effective? And especially a lot of times as people are, if they're not comfortable with pain management, maybe they're earlier in their career, they haven't done a lot of pain management, they're not comfortable with the doses that you're going to need for things like an acute arterial occlusion, where there's a significant amount of pain. So in this case, the patient received 8 doses of morphine, 2 milligrams in the last 2 hours. And I always like to ask my students, what's the definition of insanity? Doing the same thing over and over and over again and expecting a different result. So anytime you give 8 doses of something and it doesn't work, you're not on the right track. We need to do something different. No oral medicines were given. She couldn't take any. No drip was started. And so what do we want to do now? We need to decide on a medication and a route of administration. We need to calculate and administer an appropriate, immediately effective dose. But then we also need to consider our delayed interventions, our long-term pain management methods, and begin implementation of that right away. That's the step that most people will forget, is that they might get good pain control in the beginning, but they forget about what's going to happen in 2 hours from now, 3 hours from now. So we just always need to be thinking ahead. So let's implement some immediate and delayed interventions. We need to decide on a medicine and a route of administration. So we're not going to go with morphine because of her underlying renal failure. And we can't go with Dilaudid because she's intolerant. So therefore, the winner is fentanyl. And fentanyl is available in most inpatient settings. So she can't take orals. She's not in any condition to take orals. So we're going to give it IV. Patches take way too long. They take about 24 hours to get full effect. So just always consider that. That's a very common suggestion from a lot of people is the fentanyl patch. It takes about 12 hours to get really any effect. So unless you've got 12 hours to wait, don't even consider it. It might be one of your delayed interventions, but not right away. For all the students and residents on this, this is the equianalgesic dosing chart. If I could give you one piece of advice that will change the rest of your career, it is to memorize this chart. What are the reasons that people come in to see us as physicians? It's usually for a symptom. It's almost never because they just want to see us. So it's almost always for a symptom. And yes, we have to know all of the diagnoses and all of the treatments for so many different diseases. But I can tell you that if you know symptom management really well, you will excel because we use this every single day, and especially if you're working in a hospital or an inpatient setting. What do you see every single day? Pain. So usually what I do is I require that my medical students and residents memorize this chart. That in order to pass the rotation, you have to memorize it, and it will serve you well. So please consider that. I know I can't see or talk to all of you, but please consider that. And then we're going to talk about this chart as we go through these cases and how to use this chart. So let's go to back to this case. So we need to calculate an appropriate and immediately effective dose. We're going to look at the equianalgesic dosing chart. So she got 2 milligrams of IV morphine 8 times. So that's a total of 16 milligrams of IV morphine. We know from the chart that 10 milligrams of IV morphine is equivalent to 200 mics of IV fentanyl. Therefore, we know that that's about 320 mics of IV fentanyl that she got. That's about the equivalent. We need to dose reduce though, because it's not the same medicine. So I usually dose reduce by about 25% when I'm changing medications. So if it's morphine to Dilaudid, if it's morphine to fentanyl, if it's fentanyl to Dilaudid, it doesn't matter. You just need to dose reduce because the body is not adjusted to that new medication yet. And so she got the equivalent, if I dose reduce, 240 mics of IV fentanyl in 2 hours for about 100 mics of fentanyl per hour. And so our intervention is to give her what we know she can tolerate, which is 100 mics of IV fentanyl in an hour. They essentially broke it up into 20 microgram increments when they were giving it to her as the 2 milligrams of IV morphine again and again and again and again. We gave her IV fentanyl 100 mics one time, and within 20 minutes, she was no longer moving around the bed, agitated. She was sleeping quietly. She had an occasional movement of her foot, of the left foot, which we knew was still meaning that she probably still had some pain, but she was infinitely more comfortable and her family was really happy. So, however, that's not where the story ends, because remember, we need to look at delayed interventions. If we just leave her like this, within an hour, she's going to be right back to where she was. And we don't want that for her. We don't want people to have complaints of pain before we address them. Especially if we know, and we're talking about patients that have a real, obviously like a very obvious source of pain. We don't want them to get back to crisis mode. So we need to consider our long-term pain control methods. And do we want a patch? Do we want a long-acting oral? How do we want to help her for the future for her pain? So I selected a drip in her case because I did not want to, I didn't have time to wait for the patch to take full effect, and oral, long-lasting oral, she just was not awake enough to take an oral. So we started her fentanyl drip at 100 mics an hour. We know she can tolerate that. She was doing well on it. So, and then really we need to reassess frequently and maintain control. And again, that's kind of another part that people forget. They forget to put the delayed interventions in, and then they forget to reassess frequently. We were at bedside for over an hour, and then we reassessed her very frequently, like every hour afterward. And part of this is having really good connections with your nursing staff and making sure that, you know, they feel comfortable and that they're going to call you if things are not looking good, if things are starting to go the wrong way. The other thing is that I put an available bolus dose for her every 15 minutes IV push. So the nursing staff could give her another 100 mics every 15 minutes if they thought that she needed it for her pain. And then we made the drip titratable so that they could increase based on what they thought her pain needs were, and what within the, and I don't have all the criteria on the drip for this one, but I'll talk to you about it in a different case. If she were awake, this would be a great patient for a PCA, and we'll talk a lot about PCAs in the next case. So I'm just going to stop for a second and see if there were any questions. I can't see the chat again. So Dr. Masaki, were there any questions?
Gabriel, would you like to unmute and ask your question?
Hi, sure, I'd be happy to. Hi, my name is
Thank you.
Gabriel. So good to meet you. No, I was just, everybody has different equianalgesic tables, and I respect the variability in the literature. It's just the methadone to morphine ratio. I'm a little more cautious in that table, so I was just sharing that for the group.
Great, no, thank you. And that is, as you know, methadone is, there's a lot of debate around methadone, and there's a wide variance in what people will use. So that's a good point. Thank you. Any other questions or comments just before we go on?
I don't see any other questions in the chat.
Okay.
Thanks.
All right, we'll go to the next case study. So this was another patient that I saw in the hospital. And I thought he was a really great case for the medical students and residents. So 92-year-old male with metastatic colon cancer, admitted 2 days previously with worsening abdominal pain. CT abdomen showed an obstructive mass. Patient was refusing surgery. He had a long history with that cancer and did not want any further aggressive treatments. He really just wanted pain control. His pain was an 8 out of 10 on admission, and it was a 10 plus when they consulted me. So he had been in pain for a very long time, and he was a really tough guy. So I would imagine that he was in a lot of pain even before he came to the hospital. When I saw him, he was in the fetal position. He was dry heaving after many, many, many hours of vomiting. So he was in a really bad way. So did a quick situational assessment. He obviously had acute visceral pain. He was in renal failure, but did not have any medication intolerances. He had been on the watch at 50 mics an hour. He had also received 12 doses of Dilaudid, 0.2 milligrams IV, 5 doses of 2 milligrams IV morphine, 5 doses of fentanyl, 50 micrograms IV in the last 24 hours, and nothing PO because of his vomiting. So a lot of times I will see this where people have tried Dilaudid and then they go to morphine, or then they go to fentanyl and then they go back to something. And there's this idea that, fentanyl is stronger than morphine, or Dilaudid is stronger than morphine. It's true and not true. So remember that there's an equianalgesic dosing chart for a reason, and that, yes, there are things that are more potent, but you have to give a dose that's effective. And so a lot of times when people say, like, patients will often say this, that like, oh, morphine doesn't work for me, only fentanyl does, or only whatever does. And it may be really because they weren't given an effective dose. And sometimes we're the ones that are not giving an effective dose. So for example, in this case, I look at a man who's got a terrible bowel obstruction from his metastatic cancer. 0.2 of Dilaudid is probably not going to cut it. Like, that is probably not even close. And so us giving him 12 doses of that, well, that was not going to ever work. And it definitely wasn't going to work any of the 12 times. So he might say in the future, like, oh, Dilaudid doesn't work for me. Well, was it just the dose of Dilaudid that didn't work for him? So something to just kind of keep in the back of your mind. So we want to, again, calculate and administer an immediately effective dose. Chose Dilaudid. We're going to convert so how we do this, and when we look at what he's had, we convert all of the medications to one medication. So we take all of his doses of Dilaudid, the 0.2 times 12 doses is 2.4 milligrams of IV Dilaudid. We take the morphine doses that he had, and we convert them to Dilaudid. So 1.1 milligrams of IV Dilaudid is the equivalent when we've dose reduced. Again, 25% anytime there's a medication change. And then the same thing with the fentanyl. So we put all of that into Dilaudid so that we can get, instead of comparing apples and oranges and bananas, we can just do all apples. We get a sum of about 5 milligrams of IV Dilaudid in 24 hours, or about 0.2 milligrams per hour of Dilaudid for bad pain control. So think about that too. When we're giving something and we're saying, okay, this is what they've gotten, for what? For good or bad pain control? In this case, it was bad pain control. So now what do? Well, double it. Whenever you've given a dose of something, and if it's completely ineffective, it doesn't matter what it is. If it's 2 milligrams of morphine and this person's in still 10 out of 10 pain and they're wide awake 15 minutes later and 10 out of 10 pain, 4 milligrams, try 4. If it was 4 milligrams, try 8. And it's being comfortable with the idea of, I gave this medication, I gave more than enough time for it to work, and then it was not effective. So I need to go up, and usually doubling it is a good start. If it did do something, and kind of what I teach the students is, and there's an art to this. This is definitely, there's not a lot of literature on exactly how to do this. So there is an art to it. If it did do something, if you've got the same patient and instead of being 10 out of 10, they're still wide awake, but they're maybe a 6 out of 10. So maybe you're going to go only up by half. You're not going to go up from 2 to 4, you're going to go up from 2 to 3 because it had an effect. So there is that subtle art to it. But in this case, there was zero, there's essentially no effect. Let's go and double it. And so that's what we did. We reassessed after 10 to 15 minutes. Why 10 to 15 minutes? Because that's enough time for the drug to work and for people to get sleepy if that's what's going to happen. Sleep or sedation effects are going to happen before pain control, thankfully. And that's going to be really, really helpful for us with PCAs. So he got better pain control. It was about a 6 out of 10 after 10 to 15 minutes. So we knew we were on the right track. So we set his drip rate to 0.4 milligrams an hour. He had been tolerating that. We clearly gave that to him, and he was good with that. And then we set his PCA to the same as his hourly rate. And so often PCAs and drips are very, very intimidating, especially to medical students and residents, because they haven't had a lot of experience with them. I absolutely love them. They're an incredible way to get control of people's pain really quickly without overburdening your nursing staff. They're very, very safe because, again, people will fall asleep before they can overdose themselves if they're set appropriately. So in this case, where we put his drip rate at 0.4, and then we gave him a PCA setting of 0.4 milligrams every 15 minutes as needed, if he were to push the button, he gets a 0.4, he has to wait 10 to 15 minutes to push the button again to get another dose. If he's already sedated when he hits it, by the time he gets that second dose, he's going to be out. He's going to be sleeping, and he won't be able to give himself a third dose. He'd have to wake up first and then be able to give it. So as long as they're set appropriately, they can be an incredibly useful tool. And the other thing that I would say on some in a case like this is, do not forget the other symptoms. You know, you've got someone who's got a bowel obstruction. They probably have a lot of nausea. They probably have a lot of anxiety. Like, we need to treat all of the other symptoms that they're having and not just only focus on the pain. So, and so we want to reassess him frequently and maintain control. Usually we're titrating drips after 3 to 4 hours after we interrogate their PCA to kind of see where we need to move the drip to. And we'll talk about how to do that. So in this case, though, we kept a much closer eye, because anytime someone's in a pain crisis, you may not want to wait 3 to 4 hours before reassessing them and adjusting their drip. We usually wait like an hour and kind of give bolus doses in the meantime and do what we need to do. And really frequently reassess. So, but if they're not in a crisis, you usually 3 to 4 hours, because that gives you enough data to try and figure out, like, well, okay, how much do we need? Like, how much do we really need to go up? And so this came from my previous hospital. It was literally a cut and paste, not necessarily of this patient, I believe, but of a different patient, of what to look for on a PCA report out. So first thing is you want to look at their pain score. And then this you can see 7, 7, 8, 7, 8, 8 along the way. And we had 1, 5. So you want to take a look at their pain scores. Are they well controlled? What's considered good control for that patient? We want to look at the total amount of medication given in however many hours. So in this case, let's see, where is it? The shift total is like 236 was the first one, 149 micrograms the second one, and so forth. And then figuring out how many hours it's in. And each hospital is different in how they, what increments they're doing it in, and if it's 8-hour shifts, 12-hour shifts, 4 hours. Other things that people don't necessarily know to look for are, like, for example, the number of attempts or demands on the pump. And so, like in this case, if you look down, there were 51 attempts on the first one, 23 attempts on the second one, 44 on the third, on the recordings, 104 on the fourth. And that will tell you a lot. And if you think about, if someone is demanding, they have to be awake for it. And then you want to look at when they're awake. So if they're demanding 110 times during the day and they go down to 10 times at night, is the pain really that much more severe during the day, or are they just awake and kind of thinking about it, or anxious or something like that, versus someone who is consistently and persistently pushing the button every single time that it turns green? As most PCAs, the light will turn green, they watch for it, they click it because they're in pain. There's just a huge difference between someone who appropriately pushes the button 4 times an hour every 15 minutes as soon as they can get that pain medication, versus someone who's clicking it 100 times during the day and then 2 times at night when they have it because they happen to be asleep. And so it just kind of goes into how much medication you think they need, that art of pain management. You also want to look at the number of injections or deliveries, because if I push the button 17 times and I get 1 delivery versus I push the button 1 time and I get 1 delivery, obviously, like, someone is being very deliberate about it. The other person is maybe not. You want to look at the lockout time between demand doses. I usually set it for 15 minutes because that's a good amount of time that you know that medication took effect. I've seen it set for all sorts of random numbers, and I really don't know why someone set it for like 4 minutes, because that's clearly not enough time for any medication to take full effect. But you'll see it for all sorts of random times. So be deliberate about it. You know, if you're going to set it for 10 minutes or 15 minutes, like, know how long that medication takes to get into full effect. You want to look at the continuous rate. So what do we have the drip rate set at, if there is a drip rate? And then were there any rescue boluses given? So these are the boluses that are not coming from the PCA, but that might be taken off the drip by the nursing staff, so that the nursing staff can go over and instead of pulling it from the Pyxis machine, they just take it right from the medication bag. They put it in into the patient's IV that's already there. So they just bolus it off the bag. And so you want to make sure that you're not missing any of those, because sometimes that will happen. So in this case, we were reassessing frequently to maintain control. Patient was rating about 2 out of 10 pain, no vomiting. We interrogated his pump after 4 hours, and his dilaudid drip was set at 0.4 an hour, if you remember. And he had that for 4 hours in a row. His PCA was set to 0.4 every 15 minutes. And again, rule of thumb is that you take the hourly rate and you put it as the PCA Q 15 minutes. He had 17 demands and 14 deliveries. And so what that says to me is that's a very, very appropriate use of a PCA. That might be like he accidentally clicked it twice, 1 time, or a couple times throughout the shift. Like he just, hit the button twice by accident, but he was being very deliberate about, okay, that light is green, I can click it now. Okay, 15 minutes go by, that light is green, I can click it now. And so his shift total was 7.2 milligrams in that 4 hours. And so what do? We adjust his drip accordingly. He is not going to get better from this episode. He has a bowel obstruction that will likely end his life and did end his life. And so our goal is to keep him comfortable. It is not to wean him off of any pain medications. It is to keep him comfortable at the end of his life. So we put his drip rate up to 1.8 milligrams per hour, and then we put his PCA at the same dose. So we took the hourly rate and we made that his PCA dose every 15 minutes, so he could get a bolus of that if he needed. And in his case, I just thought it was relevant to mention a couple other things that we could have done. I can't remember actually if we did octreotide in his case. I think we might have. It suppresses secretion of the digestive enzymes and reduces gastric motility. So you're not getting that the spasms that come with when the bowel contracts against an obstruction. And it also promotes water and electrolyte absorption. So you're going to reduce some of the bloating, hopefully, that people will get, just to make them slightly more comfortable. You could consider a nerve block, though that would have been really challenging. And then palliative sedation is an option if you're really not able to get good pain control. So I'm just going to stop for a minute and see if anybody has questions on the 2 pain cases.
I don't see anything in the chat, Dr. Dietrich, but the audience, if you have any questions, please unmute yourself and ask now.
Hi, this is Marina. I'm one of the outpatient geriatricians. I actually have a patient right now who's I'm outpatient, but she's been she's on hospice and been readmitted 4 times for recurrent SBO, not from cancer. I think from adhesions from prior, and she already has an ileostomy. But I was wondering, is there any outpatient equivalent for the octreotide that we could consider? Or is it pretty much just have to get readmitted and decompressed? Because that's I just haven't been able to figure out any way around it so far. Sorry for it to be such a specific thing.
No, so you can do octreotide outpatient. It's just an injection. Getting the cost, I remember, was a really big deal because we had to do this on hospice at one point. I usually use it as like a last, because remember, we're kind of shutting down all gastric motility. And there's not a lot of great literature on use of it as an outpatient. So I use it as like the last ditch, we just need to make this person comfortable before they die. So if she's getting decompressed and then going back out and living on hospice and living a somewhat normal life, I don't know if that would be necessarily an appropriate case. I could talk to you about it offline, though. I'd be happy to.
So helpful. Thank you. Yeah, I'll follow up with you.
Thanks, Marina. Any other questions for Dr. Dietrich? Daniel, would you like to unmute?
Sure. Hi, Dr. Dietrich, Daniel Fishberg, Pain and Palliative Care over at Queens. I was just putting into the chat that these are pretty aggressive titrations for end-of-life care, and that for non-end-of-life situations, we usually wait until 4 or 5 half-lives have gone by and the patient would be closer to steady state before we'd adjust to continuous. Just always safer to rely on the boluses than adjusting it continuous.
No, thank you. And it is, the title of my presentation is pain crisis or symptom crisis. So I think that's really important that for the students and residents and everyone that's on the call is that, we are talking about a specific scenario, and I tried to point that out too with, in the scenario of we are not weaning these patients off. That is not my goal. It's not to help them get to the outpatient realm. These are patients that are dying, really horrible deaths, unfortunately. So.
Understood. Thank you.
Thank you. I don't see any other questions if you want to go on, Dr. Dietrich.
I think I've got about 15 minutes, so I'm going to buzz through the last symptom management. So we're going to change gears to nausea and vomiting. And I put this up just so people could see. This was cut and pasted out of UpToDate, and all of the causes of nausea and vomiting. They are very, very extensive. So just kind of keeping that in mind as we look at nausea and vomiting, that it's not a simple simple thing to evaluate. So, one of the things that we study in hospice and palliative care is the mechanisms of nausea and vomiting, and that there is a vomit center that is stimulated to cause nausea and vomiting, and that there's 4 mechanisms that cause it, that contribute to it. So I'm just gonna, again, really buzz through this very quickly. The vestibular system, the chemoreceptor trigger zone, the peripheral pathways, and the cortex. This is something that's I would say hospice and palliative boards relevant. The only reason I present this to med students and residents and internists is because, just so you know, it's out there. And then when we come to the tips and tricks section, then you'll kind of understand why. So I think everybody kind of knows about the vestibular system. If you get nauseated on the teacups, like my dad does, then you know that the vestibular system can be a very potent cause of vomiting. The chemoreceptor trigger zone is the area of the medulla outside the blood-brain, or outside the blood-brain barrier, that's exposed to toxins and drugs and other things. So that can cause vomiting. The peripheral pathways are the pathways in the gut. So the mechano and the chemoreceptors in the gut tissue that again can cause like stretch, like in such an obstruction or injury, and then cause nausea and vomiting. And then finally, the cortex. The things like that, higher level thinking can actually cause enough anxiety and stimulation to cause nausea and vomiting. So in addition to things like increased intracranial pressure, meningeal irritation, that kind of thing. So this gets very, very complicated. And this is actually when I was studying for the boards the first time, I had to write out all the pathways and then where all the medications work. And so I did that on this slide. For anyone who wants to keep it, you are more than welcome to print it out. Put it in if residents put it in your book or in your pocket, take a picture of it on your phone. This can make you look like a rock star. And this is for anyone to use. What I tell people is that when we look at the medications, basically all of the common medications have been shown to be non-inferior to ondansetron. So when we're looking at medications, really any of your choices are probably pretty good ones. However, so when we choose one, go with it, try. But you want to consider the receptor. And so what's going to make you look like a rock star is when someone calls you and they say, look, I don't know what to do. I have tried diphenhydramine, I tried promethazine, I've tried Haldol, I've tried ondansetron, I've tried metoclopramide. And you're like, okay, have you tried alprazolam? And they say, like, what? No, go for a different receptor. So, and this is literally a case that I got where I had an intern that they said, they were like, we can't, we've got this patient, we've tried everything in the ER, ER docs tried everything, like, we don't know what to do, and we're gonna have to admit them. And I said, did you try alprazolam? And they said, no. And I said, okay, well, give me a call back in like 20 minutes when you try it and see how it goes. And they were like, this is great. They're gonna go home. She was really anxious. And so you really just want to consider what receptor hasn't been hit. It's not always, it's not always the most scientific, unfortunately, of methods, but it is going to make the person feel better. And especially if they've been vomiting for hours, they're going to be very, very grateful that they are no longer vomiting. So again, this was just the quick down and dirty for this because we had a lot to cover. And then I'm going to go to shortness of breath because, again, I have about 10 minutes left. So when managing shortness of breath, just remember that dyspnea is a subjective sensation, that a person may look like they're not working to breathe. They're sitting here like I am right now, they're talking, but they might feel short of breath. They might be dyspneic. Conversely, people can have an increased respiratory effort where they are working to breathe, and you can see them and they're using accessory muscles, but they don't feel short of breath. They don't feel dyspneic. So just kind of getting the idea that just because someone looks like they're working to breathe does not necessarily mean that they're dyspneic and that you should ask them. And interestingly, back in 2002, so a long time ago now, they showed that dyspnea was a better predictor of a 5-year survival rate than FEV1. So we know that there's more factors that go into this than we really understand. And just kind of keeping that in mind as we're assessing shortness of breath. In terms of what we can do for it, proper positioning, I will say I often come into inpatient rooms and people will be hunched over, their chin is at their chest. They're often, older and they have trouble holding themselves up. They might be slumped to one side. So you really want to get them as vertical as possible and as upright as possible. Encouraging pursed lip breathing so that they increase their expiratory air pressure. And then cooling the room down and blowing a fan on their face to stimulate the V2 branch of the trigeminal nerve really does help. They will feel better usually. We also want to thin out their secretions, so using things like Mucinex, and then reduce their secretions. So things like glycopyrrolates, scopolamine, atropine drops. Remember, if you have someone that has the potential to get confused, glycopyrrolate is the only one that does not cross the blood-brain barrier, so it's a good one to use. Use bronchodilators, of course, and non-invasive positive pressure ventilation for increased work breathing. And then you want to make sure that you're treating any underlying anxiety, benzodiazepines, atypical antipsychotics if needed, or it might be things like music therapy, talking to the patient, having a spiritual care visit. There's lots of options to treat underlying anxiety. I always get the question about supplemental oxygen, and I feel like this goes back and forth pretty much all the time about whether it makes a difference. The jury is still out. So a randomized controlled trial in Lancet showed that supplemental oxygen improved exercise tolerance and dyspnea for patients that didn't meet the typical criteria. Stats less than 89% for supplemental oxygen. But then New England Journal, a few years later, published a randomized trial of 734 patients showing no change in mortality rate, time to first hospitalization, quality of life, lung function, distance walked in 6 minutes. So showing that there really wasn't any improvement. And I feel like there's probably a new study that comes out every year going back and forth on this. So again, this just goes to show that there's a lot of things that we still don't understand about this process. One thing I always like to add in is that all meds and their route of administration are equivalent. So things like inhaled morphine are no better, and in fact might actually be worse in terms of causing irritation to the lung tissue and to the airways in a patient that's already got concerning or like airway disease. And then you want to, if you are going to use an opioid to help with like air hunger, you want to start low dose, but the low doses are often as effective as a higher dose. So even something like a single milligram of morphine can make a big difference. So, and then music therapy can actually be really, really helpful. There's been a lot of more data coming out on music therapy decreasing pain, anxiety, nausea, shortness of breath, feelings of depression, and for a time period afterward, actually, as well. So a lot of hospitals are now getting music therapy. We had music therapy, and it did seem to make a big difference in patients' reported levels of pain, shortness of breath, and anxiety. So, and I did want to leave time for questions. So I have some slides on palliative sedation, but I just want to make sure that I hit any questions before I go on to those.
Does anyone have any questions or comments to share? We have many palliative experts in the audience. Please speak up if you have anything to share. I don't see anything in the chat, Dr. Dietrich. So if you want to continue, please go ahead.
Okay. So I'll just do a quick little segment on palliative sedation. For those that don't know, palliative sedation, according to the AHPM, is the intentional lowering of awareness towards and including unconsciousness for patients with severe and refractory symptoms. And I like to talk to medical students and residents, especially about palliative sedation, because sometimes the understanding of what that is and how it's used, it's kind of a term that will get thrown around, and it should be used extremely deliberately and only in certain circumstances. So it's an intervention that is reserved for extreme situations. It should only be considered after all the available expertise to manage target symptoms has been accessed. The level of sedation needs to be proportionate to the patient's level of distress. Patients, when able, should be able to participate in the decision to use palliative sedation, and the treatment of other symptoms should be continued alongside palliative sedation because sedation might decrease the patient's ability to communicate or display discomfort. And so a lot of times what I'll see is oh, we're not doing a good job of getting their symptoms under control. Should we consider palliative sedation? And we really need to recognize that this is the intentional lowering of someone's ability to communicate with us, and putting them into a medically induced coma or lowered state of awareness should really be done very, very infrequently and very cautiously. And I think probably the best advice I got, and this has remained true for myself, I would say if you're doing it more than once every 5 years, you're probably doing it too often. If you're doing it less, then maybe you're not doing it often enough, depending on the situation that you're working in. And if you're doing, and I think it's a good rule of thumb, maybe for inpatient settings, that if you're, maybe you're not considering it, and maybe it's that it's not appropriate, but I think it needs to be at the back of our mind at any given moment that it's an available tool, but it should be used very, very judiciously. And we need to have the idea that it should be, and this again is all from the AHPM, that it should be with the clear intent of alleviating symptoms and not shortening survival. I also will tell students that that this requires the entire interdisciplinary team to sign off, that this is a big event. It requires the family and if possible the patient to sign off. But each and every member of the team needs to be comfortable with that's where we are, and that we are not able to get this patient's symptoms under control. And that if we put them in this state, that they are not able to eat and drink, and that this will result in their death eventually. And so it's the true commitment that we have no other alternative. And there is a lot of debate on this, and there's a lot of, I think, misunderstanding around it. And so, and I think it's an ever evolving process, but it's at least one that we need to make people aware of, that is ongoing, because sometimes it can be used inappropriately. So it involves usually a benzodiazepine or a barbiturate drip. The goal again is relief of symptoms, and the target is the first stage of anesthesia, where we have eyelash reflex present. Nursing needs to be present every hour to reassess until a steady drip rate is achieved. And then this is a frequent reassess. This is the team meeting daily to make sure that this patient is under proper care. So, and again, I know I buzzed through that because we have 2 minutes left, and I'm just going to open it up for any questions.
Dr. Dietrich, I don't see anything in the chat, but audience, if you have any questions, we just have time for 1 or 2. Please unmute yourselves. Please unmute yourself and ask your question if you have any.
Kamal, there's a question in the chat from William Downs.
Oh, Dr. Dietrich, Dr. Downs said he surprised at how low the morphine 1 milligram PO was the starting dose for dyspnea. Over what period of time do you titrate up to a higher dose?
That's a good question. So I often, because again, I work in an inpatient setting, it's rare when I give it an oral dose. I would say most often I would give them 1 milligram of IV morphine or 2 and see how that goes. And then if it's not making any, again, if it's not having any effect after 15 minutes, I might double it. I might see. But I'm often dealing with patients in crisis situations. So I think that if you were outpatient, trying an oral 5 milligram dose, that would probably be my start. But again, I've worked in hospice, primarily in hospice, for the last like 15 years. So that's kind of a common dose for us to start with. One was awfully low.
Thank you so much. We're right out of time, Dr. Dietrich. I want to thank you again for presenting at our grand rounds. Really appreciate you doing that. And welcome to Hawaii.
Thank you.
For our audience, don't forget to complete the evaluations in order to get your CME. John has put the link in the chat box. So you can use that link to do your evaluations, and you will be getting your CME each year. Thank you again.
Bye. Thank you.
Okay. Bye, everyone.